Okay, everyone. Well, I've read some of your feedback from the mid-semester review, and I know that some of these lectures are lengthy, so I'm trying to maybe cut back. However, the kidney and lower urinary tract are my most favorite system to talk about, so if I get a little long-winded, I apologize. But I am going to try to maybe cut these down a little bit. They are important. The lectures are very important. But again, they're just kind of supplemental to what's in the book. So I don't want to bombard you. I know that the last week 4, there were some really long lectures, and I apologize for that. So I'm going to see if I can do better. I'm not making any promises because I like to, ramble sometimes. So here we go. So, lecture 13. This is where we finally officially enter the world of renal pathology. Yay. And I'll be honest with you up front, the kidney can feel intimidating at first. There are a lot of compartments, a lot of terminology, and a lot of arrows pointing in every directions on diagrams. But here's the good news. Renal pathology is actually one of the most pattern-driven systems we study. If you can answer just one question consistently, where is the injury happening, you can usually figure out everything else. This lecture corresponds to chapter in the heart textbook, and it focuses on the kidneys and lower urinary tract. So, meaning we'll look at filtration, fluid balance, inflammatory disease, obstruction, stones, infection, and renal failure. All things you will absolutely see again in real histotechnology practice. And yes, real biopsies are tiny, stressful, and emotionally demanding, but we're going to make sense of them together. Okay, renal tissue is one of the few specimens where orientation, fixation, section thickness, and stain quality can completely change the diagnosis. So everything you learn here directly translates to the lab. Fun fact before we start, if you laid out all the tubules from one kidney end to end, they would stretch over 50 miles, which explains why even small damage can cause very big problems. Let's take a look at what you should be able to do by the end of this lecture. We're not memorizing kidneys for fun, we're building functional understanding. So by the end of chapter 15, you should be able to review the structure and function of the urinary tract, recognize common renal diseases, cancers, and surgical interventions, understand the clinical meaning of symptoms like dysuria, hematuria, oliguria, anuria, nocturia, compare nephritic versus not nephrotic syndromes, identify common genetic and congenital renal diseases, distinguish autosomal dominant versus recessive polycystic kidney disease, explain causes of UTIs and kidney stones, understand immune-mediated glomerular injury, differentiate acute versus chronic renal failure. That sounds like a lot, and it is, but notice something important. Almost every objective comes back to pattern recognition. Renal pathology is less about what disease is this, and more about is the damage glomerular, tubular, interstitial, or vascular. If you master that question, the kidney becomes much less scary. So on the board certification exam or even exams that'll come up with the kidney questions are almost always hinged on location of injury, clinical symptoms, and histologic pattern, not generally obscure disease names, okay? So before we jump into pathology, we need to ground ourselves in normal anatomy. The urinary tract system includes kidneys for our filtration and regulation, the ureters for transport, bladder for storage, the urethra for elimination, okay? From a pathophysiology standpoint, the kidneys do the heavy lifting. Everything downstream, the ureters, bladder, urethra, mostly deals with obstruction, infection, inflammation, or tumors. But almost all the complex metabolic problems start in the kidney itself. The kidneys are responsible for removing metabolic waste, regulating electrolytes, maintaining acid-base balance, controlling blood pressure, producing erythropoietin, and activating vitamin D. So when the kidneys fail, it's not just a urine problem. It's a whole body problem. When you look at renal tissue under the microscope, you are typically evaluating glomeruli, tubules, and the blood vessels as well as the interstitium. Each one has a different job. Each one fails differently, and each one produces different clinical symptoms. That's why renal pathology is best approached by compartment, not by diagnosis. A fun fact, the kidneys receive 20 to 25% of the cardiac output, despite being less than 1% of total body weight. That massive blood flow explains why kidneys are vulnerable to ischemia, why toxins hit them hard, and why vascular disease shows up here early. If blood flow drops, the kidneys know immediately, and it reacts dramatically. So a wrap up before we're advancing. So far we've introduced renal pathology and reviewed the learning objectives, and we've reestablished urinary tract anatomy and set the framework for how we'll approach disease. From here forward, everything we discuss will build on one idea: structure into function that leads to dysfunction, and then that histologic pattern. If you keep that chain in mind, renal pathology becomes logical instead of overwhelming. Okay? Now that we've placed the kidneys in the body, let's zoom in and talk anatomy. You'll hear me say this repeatedly during renal pathology. Location matters a lot. The kidney is divided into several major structural regions. Starting from the outside and moving inward, we have the renal capsule. This is a thin connective tissue layer that helps protect the kidney. Then we have the cortex. This is where most of the action happens. It contains the glomeruli and the proximal and distal tubules. Then there's the medulla. This is organized into renal pyramids, so we'd find primarily the loops of Henle and the collecting ducts. Then there's renal columns, so this is extensions of cortical tissue between pyramids. The blood enters through the renal artery, branches repeatedly, and eventually drains into the renal vein. The ureter then carries urine away from the kidney to the bladder. Okay? When you gross or embed kidney tissue, orientation is critical. You should always be asking, do I have cortex present? Do I see glomeruli? Is medulla represented? Because a biopsy with no cortex is basically a diagnostic heartbreak. No glomeruli equals no meaningful interpretation. Okay? Fun fact, the kidney receives so much blood that if you injected dye intravenously, it would pass through the kidneys in less than 1 minute. That's efficiency, but also vulnerability, right? Okay, now let's talk about why kidneys are so important, because they do way more than make urine. First and foremost, the kidneys remove waste products and medications from the bloodstream. One of the most important waste products is urea, which comes from protein metabolism. So every time someone eats meat, poultry, or protein-rich vegetables, the breakdown products eventually end up filtered by the kidney. The kidney also balances body fluids, so too much water, it excretes it, too little, and it conserves it. It balances electrolytes such as sodium, potassium, calcium, and phosphorus. So even tiny electrolyte shifts can cause major clinical issues, especially potassium. That's why renal failure is often life-threatening, even before urine output changes. The kidneys are also endocrine organs, so they release renin, which regulates blood pressure and blood volume. Also erythropoietin, which stimulates red blood cell production. And this explains why patients with chronic kidney disease often develop anemia. Not iron deficiency anemia, but lack of erythropoietin anemia. And finally, kidneys help regulate bone health by controlling calcium and phosphorus and activating vitamin D. This is why advanced renal disease leads to renal osteodystrophy. Okay? One failing organ, but multiple failing systems. When kidney tissue is damaged, the consequences are metabolic, endocrine, hematologic, and skeletal, not just urinary. That's why renal pathology is always clinically significant. This slide shows you the true workhorse of the kidney, the nephron. A healthy adult kidney contains approximately 1 to 1.5 million nephrons per kidney. And here's the part students never forget. You cannot make new nephrons. Once they're gone, they're gone. That's why chronic kidney disease is progressive and irreversible. Each nephron has two major components, the renal corpuscle, which includes the glomerulus, and the Bowman's capsule. The glomerulus is essentially a specialized capillary tuft designed to filter blood. Blood enters the glomerulus under pressure. Plasma gets filtered. Cells and large proteins stay behind, at least in healthy kidneys. And so damage here equals proteinuria and hematuria, okay? Then there's renal tubules. Once fluid leaves the glomerulus, it enters the tubules. You have the proximal convoluted tubule, the loop of Henle, and then the distal convoluted tubule, as well as the collecting duct. This is where electrolytes are adjusted, water is reabsorbed, acid-base balance is fine-tuned. By the time fluid reaches the collecting duct, it has been dramatically altered by the original plasma. Okay? If the glomerulus is damaged, we end up with a filtration problem. If the tubules are damaged, we end up with a concentration problem. If the interstitium is inflamed, that's a transport problem. And if the vessels are damaged, that's a perfusion problem. This framework will carry you through every renal disease we discuss. Okay? Fun fact, your kidneys filter about 180 liters of fluid per day, but you only excrete about 1 to 2 liters of urine, meaning your tubules reabsorb over 99% of what gets filtered. That's some serious multitasking. Okay, this slide is one of my favorites because if you remember one visual analogy from renal pathology, let it be this one. The renal corpuscle looks like a pomegranate. Seriously, you have a round structure packed with capillary loops surrounded by a capsule, just like all those little juicy seeds packed inside the fruit. The renal corpuscle includes the glomerulus and the Bowman's capsule. This is where filtration begins. Everything else the kidney does depends on what happens right here. If the glomerulus is damaged, it doesn't matter how perfect the tubules are, filtration is already compromised. That's why so many renal diseases center on glomerular injury. Okay? The renal corpuscle is located only in the cortex. So if you're scanning a kidney section and you see no glomeruli, only tubules, you're likely looking at medulla, not cortex. That distinction matters diagnostically. Okay? Fun fact, each kidney contains roughly 1 million glomeruli. That's 1 million tiny pomegranates doing filtration 24/7. Now let's zoom in further and talk specifically about the glomerulus. The glomerulus is a specialized network of fenestrated capillaries designed to allow water, electrolytes, and small solutes to pass through, while keeping red blood cells and large proteins inside the bloodstream. At least, that's the goal anyway. The glomerulus has 3 critical components: the fenestrated endothelium, the glomerular basement membrane, and the podocytes with foot processes. Together, these form the filtration barrier. If any one of these layers is damaged, filtration becomes leaky. Okay? Damage to glomerular basement membrane, we get proteinuria. Damage to capillaries, we get hematuria. In immune complex deposition, we get inflammation. Okay? If you see protein in urine, think glomerulus first. Tubules don't filter proteins, glomeruli do. The histology image here shows a classic glomerulus. Round, capillary loops visible, mesangial cells between loops. In disease, you may see hypercellularity, thickened basement membranes, obliterated capillary lumens, and crescents forming. Each of these patterns tells you something specific about mechanism of injury. Fun fact, the pressure inside the glomerulus is about 4 times higher than in most capillary beds. That's how filtration occurs, and also why hypertension absolutely destroys kidneys over time. So once fluid leaves the glomerulus, it enters the renal tubules, and this is where the real chemistry happens. The tubules don't filter. They modify what's already been filtered. So let's walk through them in order. You have the proximal convoluted tubule, or the PCT. This is the workhorse. The PCT reabsorbs about 65 to 70% of filtered water and electrolytes. It reclaims glucose, amino acids, and bicarbonate. Histologically, it has tall cuboidal cells, abundant eosinophilic cytoplasm, and prominent brush borders, which makes the lumen look fuzzy, irregular, and dirty. If you see a tubule with a messy lumen, that's probably proximal. Then we have the loop of Henle. This portion is all about concentration gradients. Descending limb, water moves out. The ascending limb, sodium moves out. This system allows humans to conserve water and produce concentrated urine. Damage here leads to inability to concentrate urine. So clinically, polyuria, okay? Then we have the distal convoluted tubule, or the DCT. The DCT fine-tunes electrolytes. Histologically, there's smaller cells, a cleaner lumen, and no brush border. If proximal tubules look messy, distal tubules look neat and polite. Okay? Then there's the collecting duct. This is hormone responsive. So aldosterone results in sodium retention. ADH is water reabsorption. These ducts determine final urine concentration. Histologically, they appear large, round, pale, and with distinct cell borders. Very recognizable once you've seen a few. Okay? Tubular injury is one of the most common findings in surgical pathology. Acute tubular injury shows epithelial flattening, loss of brush border, cell sloughing, and casts in the lumens. If you can identify tubules correctly, you're already halfway to the diagnosis. Okay? Fun fact, the tubules collectively stretch over 50 miles per kidney, which explains why nephrotoxic drugs love to cause tubular damage. There's lots of surface area, which equals lots of exposure. Okay. Now let's put everything we've talked about together at the microscopic level. This slide shows a classic low-power view of renal cortex. Right away, you should be able to identify two major structures, the glomeruli, the round pomegranate structures, and then tubules, tightly packed profiles surrounding them. Okay? If you see glomeruli, you are in the cortex. So no glomeruli equals no cortex. That single observation already tells you a lot. When viewing normal renal histology, you should expect tightly packed tubules, minimal interstitial space, intact basement membranes, and open capillary loops within glomeruli. Healthy kidneys are busy but organized. Okay? Normal renal interstitium is actually very sparse. If you see widened interstitium, lots of inflammatory cells, and fibrosis between tubules, this is almost always abnormal. Kidneys are not supposed to be roomy. At high power, notice proximal tubules with eosinophilic cytoplasm and fuzzy lumens, distal tubules with cleaner lumens, thin basement membranes, minimal background collagen. This appearance becomes your baseline. Everything pathological is compared against this normal. Pathologists often say you diagnose renal disease by what's missing. Loss of tubules, loss of glomeruli, loss of architecture. Those absences matter just as much as what's present. We transitioned from normal histology into one of the most important disease processes you'll encounter, chronic kidney disease, or CKD. CKD is defined as progressive, irreversible loss of renal function lasting longer than 3 months. And that word reversible matters. Unlike acute kidney injury, chronic disease reflects permanent structural damage. Histologically, CKD is characterized by glomerulosclerosis, tubular atrophy, interstitial fibrosis, and vascular sclerosis. This is often called end-stage kidney morphology. At this point, many different diseases all start to look similar under the microscope. In advanced CKD, you may not be able to identify the original disease. All you see is scarred glomeruli, shrunken tubules, increased collagen, and distorted architecture, which is why early biopsies matter so much. Clinically, CKD is often silent until late stages. Patients may not develop symptoms until 60 to 70% of kidney function is already lost. By the time creatinine rises significantly, damage is often extensive. So fun fact, as we've said, kidneys can lose over half their function before patients feel sick. That's why CKD is sometimes called a silent disease. This slide shows the most common risk factors for chronic kidney disease, and none of them should surprise you. The number one cause of CKD in the United States is diabetes mellitus. Chronic hyperglycemia damages glomerular basement membranes, mesangial cells, and capillary loops, eventually leading to diabetic nephropathy. The second most common cause, hypertension, The high pressure damages glomerular capillaries over time, resulting in thickened vessel walls, narrow lumens, and ischemic injury. High blood pressure and kidney disease fuel each other. It's a vicious cycle. Other important risk factors include cardiovascular disease and stroke, obesity, family history, tobacco use, and being simply over the age of 60. All of these contribute through vascular damage, chronic inflammation, and reduced perfusion. Okay? If you see diabetes and proteinuria, think glomerular damage. Hypertension and small scarred kidneys, think vascular disease. In long-standing CKD, you'll see fibrosis everywhere. Patterns matter more than labels, okay? CKD affects approximately 1 in 7 adults in the United States, many without knowing it, which means renal pathology is not rare, it's actually routine. Okay. On this slide, we're looking at the clinical signs and symptoms of chronic kidney disease, or CKD. One of the tricky things about kidney disease is that many patients don't have symptoms early on. The kidneys are excellent multitaskers. They quietly compensate until they simply can't do it anymore. Let's walk through what patients may experience as kidney function declines. The first one is flank pain. So this refers to pain in the small of the back, wrapping around the side of the torso, and sometimes extending towards the abdomen. This pain corresponds anatomically with the location of the kidneys in the retroperitoneum. Changes in urine patterns. You'll often see terms that sound intimidating but are actually very logical. So frequency just means increased need to urinate. Urgency, which is sudden, strong urge to urinate. Nocturia, which is waking up multiple times at night to urinate. These occur because damaged nephrons struggle to properly regulate water balance. There's also decreased urine output. Reduced urine output, and anuria is complete absence of urine. Okay, at this point, nephron loss has reached a critical threshold. Fluid retention, or is also called edema, right? When the kidneys can't excrete sodium and water efficiently, the fluid accumulates in tissues, and patients develop swelling of the legs, feet, ankles, and hands. Think of this like a sink with a partially clogged drain. Water keeps coming in, but it can't leave fast enough. Okay. We have some urine abnormalities. So hematuria is blood in the urine, and proteinuria is protein leakage causes foamy urine. Pyuria is pus or white blood cells in the urine. These findings are especially important for us in histology because they often correlate with glomerular damage. Okay. And then we have systemic symptoms. So muscle cramps or restless legs, persistent fatigue and weakness, and high blood pressure. So remember, the kidneys help regulate electrolytes, blood volume, and erythropoietin. So when they fail, the entire body feels it. Okay. Many of these symptoms trace directly back to the glomerulosclerosis, tubular injury, and interstitial fibrosis, structures you'll later identify microscopically. Okay, now let's talk about how chronic kidney disease is detected. Because early CKD is often asymptomatic, screening is critical, especially for high-risk populations. Urine tests, so urinalysis can detect protein, blood, glucose, and cellular sediment. Protein in the urine is often the earliest sign of kidney damage, long before creatinine rises. Okay. Blood tests. Blood testing evaluates kidney filtration using markers such as creatinine and blood urea nitrogen, or the BUN. Estimated glomerular filtration rate, or EGFR. As nephron function decreases, these values increase or decline in predictable patterns. Then there's imaging studies. So ultrasound evaluates kidney size, obstruction, and structural abnormalities. CT or MRI may be used to assess masses, cysts, stones, or vascular changes. Chronically diseased kidneys often appear small and scarred, reflecting long-term nephron loss. Okay. CKD is not diagnosed from one abnormal lab value. It requires persistent abnormalities over at least 3 months. Screening is about catching kidney disease before irreversible histologic damage dominates the tissue architecture. Okay. And then this slide brings us into familiar histotechnology territory. Urinalysis, one of the most informative and cost-effective diagnostic tools in medicine. Urinalysis evaluates three major components. Physical characteristics, so this includes volume, color, odor, and specific gravity. Specific gravity reflects the kidney's ability to concentrate or dilute urine, a function heavily dependent on tubular integrity. Okay? Damaged tubules equals poor concentrating ability. Then there's chemical analysis, measured primarily by dipstick testing. This shows pH, glucose, protein, ketone bodies, nitrate, urobilinogen, bilirubin, and blood. Protein and blood are particularly important indicators of glomerular filtration barrier injury. Okay? Then lastly is the microscopic examination of sediment. This is where pathology truly shines. Microscopy may reveal red blood cells, which suggest glomerular bleeding, white blood cells, which suggest inflammation or infection, and casts formed within renal tubules. Crystals, metabolic or obstructive processes, okay? Epithelial cells, which is tubular injury. So urinary casts are literally molds of renal tubules composed of TAM horsefell protein and cellular debris. Okay, when you see casts in urine, you are essentially seeing a microscopic biopsy in liquid form. Final takeaway here is that urinalysis gives clinicians a functional snapshot and a structural hint. This is an early warning system, all without ever touching the kidney itself. Okay. Now that we've revealed symptoms and screening tools, let's talk about how chronic kidney disease is officially diagnosed. CKD is not diagnosed based on a single abnormal lab value or one bad day of kidney function. By definition, chronic kidney disease requires structural or functional abnormalities of the kidney lasting at least 3 months. That time component is important. It's what separates chronic from acute kidney injury. There are two main diagnostic pathways. The first is evidence of kidney damage with or without decreased GFR. This includes pathologic abnormalities, so identified on renal biopsy, markers of kidney disease such as proteinuria, which is most common and most important, abnormal blood findings related to tubular dysfunction, imaging abnormalities on ultrasound, CT, or MRI, and history of kidney transplantation. So even if filtration rate is still normal, persistent structural damage qualifies as CKD. Okay. Number 2 is decreased glomerular infiltration rate. So if you have a GFR less than 60 and present for 3 months or longer, with or without additional markers of kidney damage, think GFR as the kidney's productivity score. Okay. Below 60 means the kidneys are no longer keeping up with physiological demand. Why this matters for histotechnology? Well, from a tissue perspective, CKD diagnosis often leads to renal biopsy, which means light microscopy, special stains like PAS, silver, and trichrome, immunofluorescence, and electron microscopy. Your ability to recognize chronic architectural changes directly impacts diagnosis and staging. Key takeaway is that CKD is diagnosed by persistence, not severity alone, okay? Once chronic kidney disease is diagnosed, the next question becomes, what is causing the damage? Kidney pathology is broadly divided into congenital and hereditary abnormalities, inflammatory diseases, vascular diseases, metabolic injury, and neoplasms. On this slide, we're transitioning into the structural disease categories that affect renal tubule. From a histologic standpoint, these diseases typically target one or more components: glomeruli, tubules, interstitium, or the blood vessels. Okay? Chronic injury almost always leads to fibrosis, tubular atrophy, loss of functional nephrons, and architectural distortion. And once nephrons are lost, they are not replaced. Okay? The kidney compensates for a long time until it can't. That's why CKD can remain silent for years before symptoms appear. As histotechnologists, you are often the first people to see irreversible damage under the microscope. So let's begin with congenital and hereditary renal abnormalities. Abnormalities present at birth or caused by inherited genetic defects. These conditions can significantly increase a patient's risk for recurrent infections, obstruction, progressive renal scarring, and early onset CKD. So let's review the major ones shown here. We have renal hypoplasia/dysplasia. Kidneys are smaller than normal, reduced number of nephrons, and disorganized or immature tissue architecture. Fewer nephrons at birth means less functional reserve for life. Okay. Then we have the vasochoroidal reflex, or VUR, backflow of urine from bladder, and then it goes into the ureter and then the kidney, right? So it causes repeated exposure to infected urine, which leads to chronic inflammation, scarring, and then reflex nephropathy, okay? Histologically, this often produces patchy cortical scarring. Then there's renal agenesis, so absence of one or both kidneys. Unilateral agenesis may be asymptomatic. Bilateral agenesis is incompatible with life. The remaining kidney often shows compensatory hypertrophy. Okay. Then there's duplex collecting system. So two ureters draining a signal kidney can predispose to obstruction or reflux and may be incidental or clinically significant. Then there's the uteropelvic junction, or UPJ obstruction. This is blockage where the renal pelvis meets the ureter, and it causes hydronephrosis. And progressive pressure injury leads to tubular atrophy and interstitial fibrosis. Then there's multicystic dysplastic kidney. Non-functional kidney replaced by cysts. It's often detected prenatally. A normal renal architecture is absent. Histologically, these kidneys show disorganized ducts, immature mesenchyme, and absence of normal nephron development. Why this matters in pathology is that congenital anomalies often lead to chronic inflammation, secondary glomerulosclerosis, and progressive nephron loss. Even when disease begins early in life, the final histologic appearance often mimics advanced CKD. Okay? Many adult CKD cases originate from unrecognized congenital abnormalities. Let's talk about polycystic kidney disease, or PKD, one of the classic you'll never forget this gross specimen diagnoses. In PKD, the kidneys become enlarged and distorted by numerous fluid-filled cysts that arise from different parts of the nephron. Over time, these cysts expand, compress normal renal parenchyma, and gradually replace functioning tissue. Instead of nice, organized cortex and medulla, you end up with kidneys that look more like a bag of grapes that has made some very poor life choices. Sorry about that. My dryer is going off if you can hear that annoying sound. From a histology perspective, cysts are typically lined by flattened or cuboidal epithelium. It may originate from collecting ducts, distal tubules, or proximal tubules. As the cysts enlarge, normal nephrons are squeezed out of existence, leading to progressive loss of filtration capacity. With flank pain, hematuria, or hypertension, which is very common. Also, gradual progression to chronic kidney disease. So a histo takeaway here is that large cystic kidneys are not subtle specimens, and they require careful grossing to ensure representative sampling of the remaining viable tissue between the cysts. Now, there are two major forms of PKD, and they behave very differently. We have autosomal recessive PKD, which is much rarer. It presents in infancy or early childhood, and it's caused by mutations in the PKHD1. It affects primarily the collecting ducts. So histologically, you'll see diffuse cystic dilation of the collecting ducts. Cysts would be oriented perpendicular to the capsule, and a fairly uniform appearance. Unfortunately, ARPKD can be severe and may lead to neonatal respiratory distress, liver involvement, and early renal failure. These are often heartbreaking cases. Then we have the autosomal dominant PKD, or ADPKD. This is one of the most commonly encountered in adult pathology. It's much more common. It presents in middle adulthood, and it's caused by mutations in the PKD1 or PKD2. Involves multiple segments of the nephron. And histologically, cysts are haphazardly distributed. All nephron segments may be involved, and islands of relatively normal parenchyma may remain early on. Classic complications include progressive renal failure, hypertension, and the fun bonus feature, Berry aneurysms, because apparently PKD felt the need to multitask. Okay. When grossing these kidneys, orientation matters. You're not just sampling cysts, you're hunting for residual functional tissue, inflammation, hemorrhage, and then secondary changes. Yes, kidney stones, also known as why the patient is absolutely not having a good day. Renal calculi form when substances in the urine become supersaturated and crystallize, leading to stone formation within the renal pelvis, the calyxes, or the ureter. Stones can cause obstruction, which backs up pressure into the kidney and may result in hydronephrosis, infection, tubular atrophy, or even interstitial fibrosis. Okay? From a histology standpoint, the stone itself usually isn't what we're sectioning, but the damage it causes absolutely is. Some common types of kidney stones, we have the most common, which is calcium stones. These are made of calcium oxalate or calcium phosphate. Then there's uric acid stones, often associated with acidic urine. Then we have the struvite stones. This is linked to infections with urease-producing bacteria. It can form large staghorn calculi, which are extremely, extremely ouchy. And then we have the cystine stones. These are rare genetic disorder of amino acid transport. So histologic clues you might see include tubular dilation upstream of obstruction, interstitial inflammation, crystal deposition, and then secondary infection changes. A histotech reminder is obstruction doesn't just block urine, it remodels tissue architecture, and those chronic changes are often far more important diagnostically than the stone itself. Okay? Now that we know what kidney stones are, let's talk about how patients usually find out they have one, because trust me, they don't discover this incidentally. Kidney stones are famous for being dramatic little overachievers when it comes to symptoms. The classic presentation includes severe flank or back pain. This pain is typically sudden, sharp, and comes in waves as the ureter spasms around the stone. Patients often describe it as the worst pain of my life, which is saying something. Then hematuria, which is blood in the urine. So even small stones can scrape the urothelium as they move, so microscopic or gross hematuria is extremely common. Nausea and vomiting. Thanks to shared visceral nerve pathways, kidney pain and GI upset tend to travel as a very unfortunate package deal. Fever and chills. These are red flags. When stones are combined with infection, this becomes a medical emergency. Dizziness and general misery, so often due to pain, dehydration, or vomiting. From a histology standpoint, stones themselves don't usually make it to your microscope, but the damage they cause absolutely does. Obstruction can lead to tubular dilation, interstitial inflammation, pressure atrophy, and secondary infection. So when you're looking at renal tissue with unexplained inflammation or scarring, obstruction should always be somewhere on your differential radar. All right, let's shift gears from stones to tumors of the kidney. And this is where age matters. So the most common neoplasm in children is what we call a Wilms tumor or a nephroblastoma. This is the classic pediatric renal malignancy, usually diagnosed before age 5. Histologically, Wilms tumor is known for its triphasic pattern, so blastomal cells, epithelial structures, and stromal elements. Basically, it looks like a kidney that forgot what decade of development it's supposed to be in. Clinically, kids often present with a painless abdominal mass, possible hematuria, and hypertension. And the most common in adults is renal cell carcinoma, or RCC. RCC arises from renal tubular epithelium, most commonly the proximal tubules. Grossly, RCC is often golden yellow, thanks to lipid and glycogen. It's highly vascular, and it's prone to hemorrhage and necrosis. Histologically, you'll often see clear cytoplasm, delicate vasculature, and sheets or nests of tumor cells. And RCC loves to spread early, especially into the renal vein and inferior vena cava, which is why imaging and staging are such a big deal. From a histotech standpoint, these specimens demand excellent fixation, careful grossing, and clear margin identification, because staging depends heavily on depth of invasion and vascular involvement. Finally, let's head downstream to the lower urinary tract, where epithelial behavior becomes extremely important. We have bladder cancer. The vast majority of bladder cancers arise from the urothelium, also known as transitional epithelium. So key concepts here: tumors may be papillary or fungal. The distribution matters more than size, and muscle involvement is the critical turning point. Histologically, you'll be watching closely for architectural disorganization, cytoplasmic atypia, invasion beyond the basement membrane, and extension into muscularis propria. That distinction, non-invasive versus invasive, completely changes treatment and prognosis. Then we have prostate cancer. Prostate carcinoma typically arises from glandular epithelium, most often in the peripheral zone of the prostate. Classic histologic features include small crowded glands, loss of basal cells, prominent nucleoli, and as tumors enlarge, they may compress the urethra, extend into surrounding tissues, and invade bladder or rectum in advanced stages. For histotechnologists, prostate and bladder specimens are all about orientation, margin inking, and consistent section thickness. Avoiding crush and cautery artifact are also important, because tiny differences under the microscope translate into very big clinical decisions. All right, now that we've talked anomalies, stones, and neoplasms, let's zoom out and talk renal disease progression as a whole. This slide gives you the big picture timeline. You start with AKI, which is acute kidney injury, and it goes into CKD, which is chronic kidney disease, and then we end up with ESRD, which is end-stage renal disease, okay? Not every patient follows this exact path, but many do, especially when injury is repetitive, untreated, or chronic. So stage 1 to 2. This kidney function may appear mostly normal or only mildly decreased. Histologically, changes can be subtle, so mild inflammation, early basement membrane changes, or early tubular stress. Then we go to stage 3. This is where damage becomes more apparent. You'll start seeing tubular atrophy, interstitial inflammation, and early fibrosis. Stages 4 and 5 become severe loss of functional nephrons. Histologically, this looks like global glomerulosclerosis, thickened basement membranes, extensive fibrosis, and or shrunken scarred kidneys. Okay? By the time a patient reaches end-stage renal disease, most of the renal tissue we'd love to examine simply isn't functioning anymore. From a histology standpoint, this progression is important because acute injury can be reversible. Chronic injury leaves permanent architectural fingerprints. Once fibrosis replaces nephrons, there's no control Z. Here's a statistic that tends to surprise people. More than 1 in 7 U.S. adults has chronic kidney disease. That's roughly 37 million people, many of whom don't even know it yet. And when we look at the causes, the chart on the right tells the story very clearly. Diabetes is roughly 44%. Hypertension, roughly 27%. Glomerulonephritis is around 8%. And then we have cystic diseases, urologic causes are both about 2%. And then other causes is around 17%. So yes, the kidney really does suffer when the rest of the body misbehaves. From a tissue perspective, diabetes leads to mesangial expansion, glomerular basement membrane thickening, nodular glomerulosclerosis. Hypertension causes vascular wall thickening, ischemic injury, and progressive nephron loss. And what do all of these eventually have in common? Fibrosis, loss of architecture, replacement of function with scar. Histologically, CKD kidneys tend to look tired. Shiny glomeruli are gone. The tubules collapse and the interstitium expands. The slide always tells the story, even when the labs already gave away the ending. Okay? Now let's talk about one of the most testable and most clinically useful distinctions in renal pathology: nephrotic versus nephritic. Think of this as two very different problems. happening in the same tiny structure. So nephrotic syndrome, this is a leaky filter problem. The glomerulus is damaged in a way that allows large proteins to escape, but red blood cells mostly stay put. Key features: heavy proteinuria, so greater than 3 grams a day, fatty casts, and oval fat bodies, and generalized edema, and even periorbital edema. Often hypertension. On histology, we commonly see minimal change disease, focal segmental glomerulosclerosis or FSGS, membranous nephropathy, membranoproliferative patterns. So if the urine looks like a snow globe under polarized light, you're probably in nephrotic territory, okay? Nephritic syndrome, this one is an inflammatory problem. Here, the glomerulus is so inflamed that red blood cells are escaping. So key features would be hematuria, red blood cell casts, smoky or cola-colored urine, and lower levels of proteinuria, so less than 2.5 grams a day, and hypertension. So classic histological diagnoses include post-streptococcal glomerulonephritis, IgA nephropathy, or Hennig-Schönlein purpura, rapidly progressive glomerulonephritis. And a histotech pearl here is that red blood cell cast equals glomerular origin. If you see intact red cells molded into a cast, the bleeding happened upstream, not in the bladder. And final takeaway for glomerular disease: nephrotic is a protein problem, nephritic is a blood problem. Both ultimately disrupt filtration. Both can progress to chronic kidney disease if unchecked. And from our side of the microscope, understanding where and how the glomerulus is injured tells us far more than memorizing disease names ever will. Because once again, the pattern explains the pathology, not the other way around. Now we're officially entering immune-mediated kidney disease territory, which is where pathology and histology really start to shine. These disorders are driven by immune complex deposition or autoantibody attack, primarily targeting the glomerulus. Think of it this way: the immune system shows up to help and accidentally trashes the filtration unit. Depending on where immune complexes deposit, we get very different morphologic patterns, and this is where EM earns its paycheck. So common immune-mediated renal disease includes glomerulonephritis, acute or chronic, and this is often post-infectious. Lupus nephritis, membranous nephropathy, IgA nephropathy, and antiglomerular basement membrane disease, or anti-GBM. From a histology standpoint, these diseases are classified by location of the immune deposits, so whether they're subepithelial, subendothelial, or mesangial, appearance on light microscopy, immunofluorescence pattern, and electron microscopy findings. So you cannot diagnose these cases on H&E alone. This is why renal biopsies are tiny, precious, and extremely well triaged for light microscopy, IF, and EM, okay? Now, UTIs are one of the most common infections in humans, and yes, nearly everyone has either had one, treated one, or heard someone complain about one. Most UTIs occur via ascending infection. Bacteria enter through the urethra, travel upward into the bladder, and in severe cases reach the kidneys. Lower urinary tract infections include urethritis, which is in the urethra, cystitis, which is in the bladder, prostatitis, which is in the prostate. Upper urinary tract infections, we have pyelonephritis, which is kidney involvement. So once bacteria reach the kidney, things escalate quickly. You have tubulointerstitial inflammation, neutrophilic infiltration, and then tubular damage and possible scarring with chronic or recurrent infection. Histologically, in acute pyelonephritis, you'll often see neutrophils in the tubules, interstitial edema, and microabscess formation, which is basically pathology's way of saying this infection has gone way too far. Common symptoms include burning with urination, which is dysuria, urinary frequency and urgency, cloudy or foul-smelling urine, hematuria, pelvic pressure or discomfort, and fever or chills, especially if the kidneys are involved. If someone has back or flank pain plus fever, think this may no longer be cystitis. Risk factors include the female anatomy because we have a shorter urethra, we have a shorter bacterial commute, right? Catheter use, and hormonal changes, including menopause. Also, birth control methods that alter vaginal flora, immunosuppression, and incomplete bladder emptying. Okay. Treatment, antibiotics, so culture directed whenever possible, hydration, and addressing the underlying causes. From a lab perspective, diagnosis commonly involves urinalysis and detection of leukocyte esterase, nitrates, white blood cells, and bacteria. Urine culture for organism identification and sensitivity is also used, and yes, this is why urine is one of the most frequently examined specimens in the clinical lab. All right, before we wrap up, let's take a quick brain break because pathology is heavy and sometimes we all need a weird anatomy fun fact. So, did you know that male will activate a female giraffe's bladder until she urinates? Once she does, the male giraffe tastes the urine to determine whether she's ovulating and able to mate. Yes, urine tasting is apparently a legitimate reproductive strategy in the animal kingdom. From a physiology standpoint, this actually makes sense. Hormones and pheromones are excreted in urine, so it gives the male information about reproductive status. From a human standpoint, we're all very glad this did not make it into our evolutionary pathway. But it does highlight something important that ties directly back to this lecture. Urine isn't just waste, it's packed with biochemical information. That's why urinalysis can tell us about kidney function, metabolic status, infection, immune activity, and systemic disease. So while giraffes may be out here doing whatever that is, we rely on dipsticks, microscopes, and stain slides instead. Much more professional and much less awkward. And that brings us to the end of this section on renal and urinary pathology. We covered a lot. And from a histotechnology perspective, remember, your slides are telling the story. Is the damage glomerular or tubular, acute or chronic, immune-mediated or infectious? Is there sclerosis, fibrosis, inflammation, or necrosis? Every H&E, PAS, trichrome, or even silver stain is giving you clues about where the injury started and how long it's been happening. So if questions come up as you review the material or if something just refuses to click, just reach out. You can contact me anytime at my email. I'm always happy to walk through concepts again, review images, or help connect what we're seeing under the microscope. Thanks for sticking with me through this unit. Kidneys may be small, but they cause big problems when they misbehave. Okay? And with that, we are done with this lecture.